Advanced Neurosciences in Franklin, Tennessee is hosting this NeuroNexus event. I'm joined here by Dr. Cockwood from the Shapiro Center for MS in Minneapolis, Minnesota, and Dr. Hunter of Advanced Neurosciences. And I'm Dr. Daniel Cantor of the Florida Society of Neurology. When we hear about multiple sclerosis, almost the next question becomes, how do you diagnose MS? Dr. Cockwood, you're not just a neurologist, you're actually a neuro-ophthalmologist, which means that you're a neurologist who also deals with that nerve that we call cranial nerve number 2, or the optic nerve. How do we diagnose multiple sclerosis?
Well, fortunately, being a neuro-ophthalmologist can be quite helpful in diagnosing MS, in part because MS tends to impact the visual system quite frequently. And when the visual system is perturbed, it tends to get people's attention. Another reason people are diagnosed with MS commonly is because of sensory symptoms or paresthesias. I think everyone's had the experience of where they had a little tingling in a leg or a foot or something that lasted a while and went away. So when something like that happens to someone who has MS, they're a little more likely to ignore it, blow it off, it goes away. If you suddenly get double vision or loss of vision in one eye or the other, that tends to cause people to go see a doctor. Now, many people with MS will see an ophthalmologist or an optometrist before they ever see a neurologist. It's important that the optometric and ophthalmology community of physicians be very clued in to the visual issues that can occur, simply because, as we've learned, diagnosing the disease early and treating the disease early has a much better impact on the long-term outcome of disability. So it's important that essentially our first line of diagnosis is often the ophthalmologist, or sometimes the neurologist will see that patient for a visual issue initially. Diagnosing from there becomes a little more difficult. It would be great if we had a thumbs up, thumbs down test that said, yes, it's MS, no, it's not, but it still unfortunately remains a clinical diagnosis that we support with various laboratory findings like MRI scans, spinal fluid abnormalities. Perhaps there'll be a role for neurofilaments in the future as we gain more experience with this, and other ways that we may be able to identify this disease very, very early in the course.
Dr. Hunter, how do we diagnose MS?
Well, we have some time-honored ways of doing that we've modified through the decades to try to add knowledge and additional capability through testing in the laboratory and with imaging. And the time-honored way of diagnosing MS for over 50 years is what we call dissemination, which means spreading out in space and time. By space, we don't mean outer space, we mean the nervous system, the central nervous system. And there are basically a few areas that we can easily distinguish clinically, and that was the original idea: optic nerve, spinal cord, brain stem, cerebrum. And then when we got MRI, in the last 20 years, we've added MRI-type lesions as well, characteristic lesions that are in positions in the brain near the inside of the brain or the outside of the brain or the brain stem or the spinal cord that allow us to say, yeah, this disease has spread out in the nervous system. And we know that that's not enough. You have to have symptoms. Okay, so it's not just somebody who has a brain scan that's abnormal. And then we added this dimension that's called dissemination in time to get what we call clinically definite MS. We have what's first symptom MS is somebody comes in with a symptom and they have an abnormal MRI. And we know that it's fine to treat people like they're going to have MS. But for research purposes, we usually call it definite MS if there's evidence that it's changed. And change is either a new problem that somebody has that's clearly different than the prior one, usually in a different location, like somebody had an optic nerve problem, now they have a spinal cord problem. And neurologists know how to separate these out. It's not hard to do for us. That's what we're trained to do. Or nowadays we can say there's a new problem on MRI. And 90% of people who come in for the first problem will have a new problem on MRI within 2 years when you look at it very carefully. The other thing that's recently changed is while we always have considered and used spinal fluid, it's just been decided that if the spinal fluid has typical abnormalities for MS, that meets our criteria for dissemination in time. That means it's been going on for quite some time already. We know that a substantial fraction of people at the beginning of disease have a negative spinal fluid test, and this seems to be both time and severity related. And so it's declined in importance. The spinal fluid can only say yes, it cannot say no in terms of what if someone has MS or not.
When we're looking at diagnosing MS, we use obviously the clinical aspects, the history, the neurological examination. Often feels like a Simon Says, lift up your arms, put them down, not too fast. But we also use things like MRI, we use lumbar puncture or spinal tap, and we also use things like evoked potentials. Evoked potentials are electrophysiologic tests that can help us in seeing a lesion, not just in seeing it in terms of an MRI, but if we have slowing of conduction, so if we have slowing of the way the nerve impulses are going, then we might say, well, why is that happening? And oftentimes when we see that, either in the visual processes, so the visual evoked potential, if we see that in the brainstem with the clicking, or if we see that in somatosensory, so in the upper extremities or lower extremities, that might tell us that there's a problem in the spinal cord or in the brain. All of those things together can be useful in diagnosing MS. What's changing is that we're starting to have laboratory testing. And maybe we'll be able to do a blood test that will be able to help us with that thumbs up or thumbs down of multiple sclerosis, but we're just not there yet. So for now,
Dr. Cantor, we do laboratory testing, and I've had this question from patients to say, well, you check my labs, can't you do the blood test for MS? And so I think one of the reasons, and it's important for patients to understand, both the laboratory testing we do on blood tests as well as the spinal fluid, as you, Dr. Hunter, have said, the spinal fluid can be completely normal in someone who actually has MS. So I always emphasize to the patients that you know, it's important to look at the spinal fluid, not just to diagnose MS. We may not be able to diagnose MS from your spinal fluid, but to our point of we don't have a it is or isn't MS test, it's a diagnosis of exclusion. We do the lab test looking for other diseases that might mimic MS or cause the same symptoms or cause lesions in the brain, as you alluded to, the spinal cord being more specific to MS. I think labs are important, and it gets a little confusing for patients. Well, you're doing blood tests, can't you just do the MS blood test? It's like, or just do the spinal tap and tell me whether I have MS or not. So I think it's a little complicated, but starting from that premise of it is a, what medical people call this, it's a diagnosis of exclusion. We can have dissemination in time, we can meet all of the criteria of the McDonald criteria, including spinal fluid, but is still predicated on eliminating any other disease that might more likely cause the symptoms and findings more likely than MS.
I want to thank you, Dr. Hunter. I want to thank you, Dr. Colquitt. I want to thank Advanced Neurosciences Institute for hosting this NeuroNexus event.